Other than expanding mental health services in primary and community care settings, we must also continue to ensure the safety and quality of services. I thank Dr. Said Harun, Ms. He Ting Ru, Ms. Rachel Ong, and Ms. Razwana Begum for their suggestion to introduce regulatory frameworks for psychologists and other professionals. I would point out that this space is not entirely a vacuum today. There are indeed some regulatory processes and frameworks in place. Today, services provided by clinical psychologists in healthcare institutions are subjected to the clinical governance framework of these healthcare institutions and existing healthcare legislation, such as the Healthcare Services Act. In a non-healthcare setting, such as MSF-funded early intervention programs, the operators do indeed employ mental health professionals, including clinical psychologists, to provide therapy services. And these funding agreements for these services specify the minimum qualifications and training required before staff can be deployed to provide such services. So there is some regulatory framework in place, but members have made the point that perhaps it is insufficient for our situation today and potentially insufficient for the outcome of the shift that our national mental health strategy will engender. Psychology practice is evolving. It already encompasses diverse fields with their own unique safety concerns. So MOH has been working already with agencies, with service providers and professional associations to update the risk assessment, and that updating of the risk assessment will have to take into account then what developments occur in the field in the near future. Review and study these findings and study the possible need to regulate clinical psychologists. So I thank members for their suggestions. There's, I think, not a consensus among the suggestions within the House from which professions need what type of regulation. So we will study all of the suggestions that are being made very seriously and look at these possibilities. But we will also engage peer supporters and frontline personnel that are not within the healthcare and social space. They will be trained to identify mental health needs and provide psychological first aid if needed. And so the term is appropriate. Just as you don't need to be a healthcare worker to provide first aid, it's something that all of us can do. We want to train people to be able to provide psychological first aid, even if they're not a healthcare worker or a care professional. So today, over 48,000 frontline personnel, including school teachers, officers from agencies such as Singapore Police Force, Housing Development Board, Central Narcotics Bureau, social service officers, and family service centers, have been trained together with 54,000 volunteers to recognize and provide basic emotional support to individuals in need and to refer these individuals for further support as needed. The eventual goal is to extend this training approach to over 130,000 frontline personnel and volunteers by 2030. So to have a broad network of support in individuals for mental health need. As a safety net to meet the care needs of individuals with severe and chronic mental health conditions, MOH will be expanding our hospital and our long-term care capacity. And this will be supported by plans to expand the pools of psychiatrists and psychologists in our public healthcare institutions, as has already been shared. So the balance of that capacity increase will be different depending on whether we're talking about inpatient psychiatric beds at places like IMH and the redeveloped Alexandra Hospital, and compared to, for example, long-term psychiatric care capacity. And we hope with all the things that we're doing with our mental health strategy, while we will increase inpatient acute psychiatric capacity, the need for that will not be so significant because of the things that we're doing upstream in the population and in the community. But we'll continue to need some increase in facilities in long-term psychiatric care capacity. So today we have almost 1,000 acute psychiatric beds. By 2030, this will be 1,070. Today, we have 3,000 step-down residential care beds, long-term psychiatric care facilities, and by 2030, we will have 3,500 of such beds. So the balance is on the long-term residential psychiatric care.